clinic dedicated to scleroderma patients, and she's presenting data on mesenchymal stem cell transplantation in systemic sclerosis.
Thank you, Tobias. Thank you to everyone. I am happy to be here to share with you hopes but doubts about mesenchymal stem cells in the field of scleroderma patients. When we rheumatologists think about scleroderma treatment, we feel a kind of frustration because really we have not a sure therapy for treating our patients. And this is true even if now we know better the pathogenesis of the disease, and you can see that it is a little bit complicated, and a lot of clinical trials have been made based on immunosuppressive treatment and now more recently antifibrotic therapies. But despite that, all these trials and all these attempts, it's very difficult to overcome the formidable barrier that the key actors in the pathogenesis of the disease, the vasculopathy, the fibroblast and the fibrosis, and the immune system make and leave our feeling of frustration is based on this fact. So we rheumatologists, we look at mesenchymal stem cells as an opportunity based on the fact that mesenchymal stem cells have some function that are so good for the pathogenesis of the disease, because you know better than me that mesenchymal stem cells have an antifibrotic action, that they have a pro-angiogenic effects, and that they have an immunosuppressive action. So the key actors of the disease can be in some way modulated by, could be in some way modulated by mesenchymal stem cells. During my speech, I'll speak about the better known sources of mesenchymal stem cells. And speaking about the bone marrow mesenchymal stem cells, the first question is, but the bone marrow of a scleroderma patient is normal or not? So we looked at this feature in some years ago, and we showed that the bone marrow of a scleroderma patient is normal. There is no reduce in the macrovascular density. There are no fibrotic changes, and in fact, usually scleroderma patients have no hematological disorders, or they are very rare. So the second question is, but the phenotype and the function of bone marrow mesenchymal stem cells are as controls? The answer is no, since they have no, and another Italian group demonstrated that bone marrow mesenchymal stem cells from scleroderma patient have a reduced proliferative capacity, and the possibility, the opportunity to differentiate is not the same as normal controls. And in addition, they have a senescent phenotype. In addition, a Dominique group demonstrated that these cells from bone marrow have a higher expression of TGF-beta receptor, and you know that the TGF-beta signature is an important signature of scleroderma tissues. And again, what about the capacity of these cells to promote angiogenesis? We have some cells that are not so normal in their proliferative capacity. They are not normal in the expression of some markers, but they can push the angiogenesis. That is another important effect, action that we need in scleroderma patient. And what about the immunosuppression, despite the fact that these cells have a TGF-beta signature, a pro-fibrotic signature, they act normally as immunosuppressive agents. In fact, they can decrease, as you can see, the proliferation of CD4. And another important feature is the fact that these cells can induce the emergence of Treg cells when co-incubated with CD4 lymphocyte of scleroderma patients. What about another source of mesenchymal stem cells? You know that now is a kind of a fashion to speak about the adipose tissue as a reservoir of this kind of cells, and we recently demonstrate that in the adipose tissue-derived mesenchymal stem cells have normal proliferation capability, have a normal phenotype, and can differentiate in different tissues as a control do. Again, the immunosuppression action is preserved, and again, these cells can promote angiogenesis when they have been incubated with endothelial cells, and this activity is increased in hypoxic condition. And you know that the tissues of patients with scleroderma are hypoxic tissues. These results have been confirmed by another group, and even if they demonstrate a minor proliferation capacity in comparison with our results, but the trend is toward normal activities in this kind of cells. And as you can see from, we have some experimental in vitro data, but we have only in vivo studies, and you know that in wine and in vivo, let me joke with the term, with the words, in vivo veritas. So what about the animal models? You know that there are a lot of studies showing the antifibrotic effects of mesenchymal stem cells in animal models of fibrosis and lung fibrosis in particular. But when we look at the experimental animal models of scleroderma, we have some problems. We have some problems because really there is no an animal model that faithfully cover the expression, all the expression of the disease, of the human disease, and most of the studies analyzed the acute effect of bleomycin on the fibrotic tissue and not the chronic effect of the exposure to pro-fibrotic agents. But we have some data, because in this paper it was demonstrated that bone marrow mesenchymal stem cells in this genetic model of scleroderma mice can induce a decrease in the titer of autoantibodies, can induce an emergence of Treg cells, and what is important, reduce the fibrotic effect of the fibrotic signature, the fibrotic features of the disease. Another important model that is a model deriving from the exposure of mice to oxidants and the hypochlorite overall, is a model that is so similar to scleroderma patients, because in this model we have autoantibodies, we have vascular feature, and we have fibrosis. And this group showed that mesenchymal stem cells are effective in reducing the fibrosis in this animal model. But what is important is the observation that the treatment with the bone marrow mesenchymal stem cells and with adipose-derived human adipose-derived and human bone marrow mesenchymal stem cells can reduce the fibrosis, can reduce the expression of markers of fibroblast activation. And this is true in the skin and it's true in the lung, where the results, as you can see in these morphological studies, are very, very impressive. But what we have to say about the human from the in vitro to the animal models, but what we know about the humans. Really, the studies in the humans with the mesenchymal stem cells are very few, because there are some problem now in my country, and I think in other countries, about the use of and the separation of mesenchymal stem cells. But what is important is that all these case reports, because they are case reports, showed that the mesenchymal infusion treatment with mesenchymal stem cells from a bone marrow were effective almost in the vascular feature of the disease. And in the last study, 5 cases of scleroderma were observed with allogenic mesenchymal stem cells from a bone marrow, and it's very difficult in a few patients with the heterogeneity that characterizes these patients. It's very difficult to arrive to some conclusion. And the time of observation was very, very little. We have more results about the use of adipose tissue-derived mesenchymal stem cells, and it's funny to think about the fact that the first study was from a plastic surgeon that was worried about the mouth of this patient and about the aesthetic of the patients with scleroderma patients. And after that, there were other studies regarding the treatment of the Raynaud from a bank, the treatment of the skin fibrosis, and we were involved in the use of lipofilling in the treatment of fibrosis, but more than that, on the treatment of digital ulcers. And we showed that the treatment with adipose tissue, the mixture of cells, including not only the mesenchymal stem cells, but growth factor and I don't know what is in the adipose tissue, induce a rapid healing of digital ulcer, with the demonstration of an increase that was associated with the healing of vascularization, improvement of vascularization of the digits that were treated. And this is the last study that it was by the Japanese group, and they treated with umbilical cord mesenchymal stem cells 5 patients with scleroderma, and they observed they arrived at some conclusion about the treatment again of the ulcers and the reduction of the modified Rodnan skin score. So I think that we can conclude that we have a lot of hopes, as I told you, but we have a lot of doubts, and probably we have to target our efforts to select the patients and to select the cells too. Thank you.
Thank you, Nicoletta. Are there questions from the audience?
Is there any value in using combining stem cell mesenchymal cells with hematologic stem cells in sick patients? Do you get any more support for those patients if they have sick cells?
I know that there are some data about the use of adipose mesenchymal stem cells with platelet-derived some enrichment of a platelet, but only in the local use, because all the data that I show with you are about the local treatment of adipose tissue-derived mesenchymal stem cells. And I have not idea, and I don't know, Dominic, what is your... there are not data about other kind of treatment.
I have another question. Apart from the appropriate source of the stem cell is the route of administration. Do you think in the future this will be something delivered intravenously or directly into the tissue?
I think that it depends on what we are looking for. Because if you think about the mesenchymal stem cells in the regenerative issue, you can probably expect something from the local injection. But if you want to observe something like immunomodulation, like immunomodulators, probably the infusion is the best way. But in my opinion, we are far from these observations. And if you use the intravenous infusion, then the first stop is the lung. So probably we could look at the lung as a target of our intravenous therapies.
Thank you very much.
Thank you, Nicoletta, and I'd like Dr. or Associate Professor Emilia Snarski from University of Warsaw to take the stage to summarise the Polish experience of HSCT for autoimmune diseases.